Medurstand Understanding Medicine.
I'm Professor Aziz Rehman from Medurstand-Understanding Medicine. And today we're going to talk about this very interesting and important concept called holistic approach to the management of diabetes. I've got several videos on different aspects of diabetes, but this you can take as a summary covering all components of diabetes which we need to cover, which we need to treat so that patient can have a comfortable life without morbidity and without mortality. Translate into practice. So these four alphabets A, B, C, D of course can be easily remembered, and A stands for A1C. A is derived from A is derived from HbA1c, and that means glucose control. And this HbA1c should be individualized. As far as ADA guidelines are concerned, for majority less than 7, but in some individuals you should achieve better one. Now let's talk about the second part, which is B, blood pressure. In blood pressure, the goal should be less than 130/80. If you read hypertension guidelines like JNC8, they say the blood pressure, once you start treating somebody, blood pressure should be below 140 and below 90. That may not be appropriate or optimum for patient with diabetes. I think we should try our best to bring their blood pressure around 130 and around 80 if they can tolerate antihypertensive medication without side effects. Of course, we do not want to give them side effects, but try to gradually bring it down to 130/80. Most of the time, the reading should be below or at this level. And you could use the available agents, and even in general guidelines of hypertension, angiotensin converting enzyme inhibitors or angiotensin receptor blockers are preferred agents, but it is particularly true in patients with diabetes. Now, if somebody is not controlled with either of the two, then you can add amlodipine. You of course never combine these two. Then SGLT2 inhibitors, though they are not antihypertensive drugs, but I'm talking about this category in this section because they are primarily anti-diabetic agent, but they do have modest blood pressure lowering effect also, because they are actually sodium glucose co-transporter inhibitor. So they would allow some sodium and glucose and water to pass through the urine and bring down the blood pressure a bit. So that is why I'm discussing about SGLT2 here, although they're not antihypertensive drug. Similarly, finerenone, if somebody has severe hypertension, refractory hypertension, then we use MRAs, mineralocorticoid receptor antagonists, as a fourth stage, and finerenone is also a MRA, a latest non-steroidal. As far as blood pressure lowering effect is concerned, it is a modest effect. This spironolactone is much more effective, but here I'm discussing it because finerenone has got some main benefits on diabetic nephropathy. So if somebody has diabetes and has got hypertension which is not controlled and has got a bit of nephropathy, I think finerenone can be added. So primarily aim is to bring their blood pressure to less than 130 and less than 80 without symptoms of hypotension, without postal hypertension, preferably using ACE inhibitors and ARBs. And these two agents of course are optional and can be added. So different combination. Usually, as far as European Society of Hypertension is concerned, they recommend that for majority, when we treat hypertension, we should start with combination. And the best combination is ACE inhibitors or ARBs plus amlodipine. So we can use that combination, and that is available in one pill also. We can use that, I think, for the convenience of the patient. Thank you very much for your patient listening, and I would request you to join my other videos also. This has been Professor Aziz Rehman for Medurstand Understanding Medicine.